I've talked about it previously, but I wanted to just bring back up because I'm getting guys reaching out or coming from other clinics that have been saying that just because they're on testosterone, they're automatically needing to be donating blood every 2 to 3 months. I never want to discourage blood donation from the benefit of the community. I worked in the ER, we always need blood. But just because you're on testosterone does not mean that you have to be on a routine blood donation schedule just because you're on testosterone. This comes from because testosterone does make you produce more red blood cells. This is called secondary erythrocytosis. Stimulates red blood cell production through its effect on the kidneys and erythropoietin, which signals your bone marrow to make more red blood cells. And so the logic was more red cells, thicker blood, higher chance of clots and DVTs, pulmonary embolisms, that kind of thing. The thought on that is really because they're extrapolating that from Polycythemia Vera, which is not the same as testosterone-induced secondary erythrocytosis. In Polycythemia Vera, you do have elevated red blood cells, white blood cells, and platelets, plus platelet dysfunction, and that is the big kicker on why you do have an increased risk of clots with Polycythemia Vera. In testosterone therapy, it's just the red cell goes up. So there's no elevation in white blood cells, there's no elevation in platelets, there's no abnormal platelet function. And so the mechanism and the risk profile are completely different. We've had tons of studies to help us look at this to see if putting a guy on testosterone therapy is going to cause increased clots. And luckily we do have the Traverse study. I've mentioned that a few times. It was just a big study that even followed high-risk individuals, and they did not have any increase in heart attack, stroke, blood clots, and this was the big reason the FDA removed the black box cardiovascular warning on testosterone therapy. And another just kind of, this is a niche population, but we do have data from extreme environments like the Andean highlanders, and they live at way high altitudes. Their hematocrits can be over 70%. Which is outrageous. That's just almost never seen, not even close with testosterone. But they did studies and their clotting profiles are normal and their rates of stroke or DVT are not increased. This is a different setting, it's niche, it's a small population, but it just shows that an elevated hematocrit just by itself is not a smoking gun for clot risk. Again, I don't want to discourage blood donation for the benefit of the community, especially if you're doing it for just the benefit of the community and everybody around you. But frequent blood donation can be harmful if you're just letting out a pint of blood every 2 to 3 months without letting your iron stores replenish, and your ferritin can drop to almost nothing. When you have low ferritin, low iron, this can bring up symptoms of things you probably struggled with low testosterone. Fatigue, decreased exercise tolerability, decreased muscle recovery, dizziness with position changes, shortness of breath, sometimes even hair loss. And the bad thing is it takes months to get these iron stores back. It's hard to get this iron absorbed through your gut, and we do provide iron supplementation, but it takes months and months to get you back up to adequate levels. And so the Endocrine Society recommends that if your hematocrit gets above 54%, that you should donate blood. And yes, we're going to be following that in your treatment. If I see a guy that's consistently bumping up above 55, 58, I'm going to be looking more for why, because I know testosterone is going to increase that a bit, but if it's getting up to those higher levels, there's typically some sort of underlying factor that's contributing. The biggest thing I uncover in Texas, where we don't live at elevation, is undiagnosed sleep apnea. Sleep apnea is essentially where you're suffocating a third of your life, and that's going to be increasing your body's production of red blood cells to try and meet those hypoxic episodes overnight. So I have a super low threshold to order a sleep study for a guy if their hematocrit's above 54% on follow-up labs. And getting a CPAP on board is also just truly beneficial just for overall quality of life. It can be close to impactful as getting you on testosterone, because getting the CPAP on board, one, keeps you where you're not suffocating a third of your life, but it improves your blood pressure. It improves energy throughout the day, so you can sit at a desk without feeling like you have to fall asleep. It's going to improve your erectile quality. So That's the biggest thing that I uncover if I see these guys with consistent elevated hematocrits. There's some other contributors. If you've started smoking, a lot of times I can pick that up, even vaping. And so that's why we are super hesitant or may not even treat you initially with testosterone, because if you have a hematocrit of 53 prior to starting testosterone, we know we're going to be chasing that. And a lot of times we'll forego testosterone therapy until you can have complete smoking cessation. If you live at altitude, it's more common just to be higher. Even dehydration can draw it up. So I do like you to try and drink a couple bottles of water prior to getting your labs, just so we get an accurate representation. And so if the numbers still stay up despite you're compliant with the CPAP, you say that you're hydrated, you're not smoking, you haven't been staying half a year at elevation, we may switch you to cream if the numbers are bothering you. They don't seem to have as much impact on the secondary erythrocytosis, but also smaller, more frequent injections will help make it a little bit better. Sometimes switching to sub-Q over intramuscular may have a lower impact on it as well. The big injections once every 2 weeks that people are always promoting are the best. I switch guys from those when they have elevated hematocrits, and it does much better with smaller, more frequent injections. Also with your hydration, make sure you're getting enough fluids with electrolyte replacement. Another thing that just helps at baseline to prevent it is make sure that you have some sort of low intensity, steady state cardio in your regimen. Some people will, make this LISS as an acronym. Walking, cycling, or easy jogging can all fall into this category. And they can help keep hematocrit in range by increasing plasma volume. When plasma volume expands, hematocrit goes down even if the blood count stays the same. And so it's a little bit of what's called hemodilution. And this can improve circulation, oxygen efficiency, hydration. It's also just good for your heart, and zone 2 cardio is probably the best for fat loss itself. And so even 30 minutes, 3 to 4 days a week can make a measurable difference on your hematocrit. All right, thanks for hanging in with that. But just to wrap up, therapeutic phlebotomy, that's a fancy word for blood donation, has a role in testosterone sometimes, but it's just not a blanket requirement across everybody. We need to individualize the approach, fix the underlying causes, and don't let a random guy tell you that you're going to have a stroke because you're on testosterone and you're not donating blood.